A few more soft tissue injuries as well as musculoskeletal. This kind of combines. I believe everyone has suffered some type of eye injury where they put some kind of dust or particle in the eye, or they've hit their eye. I think everyone has had some type of bit down on their lip, their tongue. They may have also suffered bumping of their head, nosebleeds. So we've had some experience with our own type of injuries. We're going to go over this. Again, it goes back to decapitalis, deformities, eviscerations, contusions, avulsions, abrasions, penetrations, burns, tenderness, lacerations, and swelling. Alright, so the eye itself, we have the covering over the eye, which is the eyelid. Underneath the eyelid is a vascular tissue called the conjunctiva. Then we move over to the corneal surface and the sclera. Sclera is the white part. The corneal surface covers over the visual field of the eye. Then we have the color part, which is the iris. Behind that is the pupil that constricts and moves with the iris. And then we have the lens, which focuses things. It then is maintained in this type of shape based on these different types of humor or fluid. Anterior, we would have the aqueous humor. Posterior, we have the vitreous humor. Blood supply is given through the retinal artery. Focus everything, visual display on the retina, then which causes and sends a signal back into the brain to be the visual cortex for it to be analyzed and interpreted. Here is the skull and facial bones. We have the frontal bone right there. We also have the orbits. We have the the maxilla, mandible, the zygomatic arch, temporomandibular joints on the side. And this is basically showing us some areas that the facial bones can receive fractures by blunt force trauma. The fracture, if we start off on the far left hand side, we're going to fracture the mandible directly in half. Then that type of trauma could also affect the TMJ or temporomandibular joint, which is not shown in this picture, but we can assume that it's just behind that mandible where it articulates with the temporal bone. The maxilla is not necessarily entirely fractured, but it is separated from the zygoma. Then we have the zygoma, and it fractures up towards above the nasal bone, towards the right hand side. As you move towards those last two pictures, we have the fracture over the nasal bone that can fracture into the orbit, and then we have a zygomatic fracture on the far end. You can imagine that if the person had this type of the middle left, this type of fracture would cause the face to really droop, and that's a type of Lafort's fracture, which we don't necessarily go over in this level of training, but significant enough to cause even some kind of brain injury and maybe even spinal cord. A lot of swelling and tissue swelling would result from these type of injuries. Here we're looking at the blood vessels and arteries, as well as some organs and tissues that lie in the neck that we can become familiar with and worry if they have some type of injury. As the carotid is lacerated here and bleeding out, without putting any pressure on that, the person can bleed out and end up in hypovolemic shock, hemorrhagic to be exact. This would sever and decrease blood circulating to the brain through the internal and external carotid. They're also showing us laceration, looks like over the jugular vein, which empties blood from the cranial vault back down into central circulation back into the heart. Now we have other blood vessels that run along, and the organ that's in front of the cartilage just below the larynx is the thyroid cartilage, and behind it posteriorly of that organ is the parathyroid organs. They also show us that you can have a trachea that's fractured, and there may be other derangements if they cut off along the tissue, sternocleidoid, mastoid, platesius. These muscles also hold the neck and neck infrastructure in place it can displace and obstruct the airway should they have a laceration deep enough. Now we would have to put a lot of pressure on that, and not to circumferential pressure to block out both carotids. Here they're showing you an inspection for the pupils. You may have to use your own fingers to open up the eyelids so that you can check the pupils and check for any type of obstructions or things in the eye. Here they're showing you the movements of the eye from right to left and up and down to make sure that the eyes have symmetrical movement and that both sides follow each other. Here they're showing you quite irritated blood vessels in the sclera, and the conjunctiva is very irritated. It looks like they may have had something in there, and so they dilated the pupil. They added some dye, and they went and looked for maybe some kind of abrasions over the cornea. But you can tell how irritated and inflamed this eye is. Again, we've seen this slide before. They're diluting, they're flushing this eye with copious amounts of fluid, maintaining that they only flush to a side where they're not going to cross-contaminate the eyes. And this may be irrigation for over 30 minutes. Here they're showing you the application of using a cotton swab to open up the eyelid and therefore to remove any type of object. This may be quite tricky in that sometimes these objects may be embedded quite deeply and may require some topical anesthetic, and maybe a more advanced method of removing this. Try to flush it out, and then they're using just a cotton tip to try to wick it out. Here we have injury to the lower eyelid. Now this can cause the visual field to become obstructed, but enough trauma to cause this type of injury could have also caused severe damage to the globe itself and the orbit. So we can, test to see if they can see well, but there is going to be some transference of blood clouding that visual field. Again, we don't want to put a lot of pressure directly on the eye, but we can kind of control the bleeding, and in some cases we may put a soft covering over that and cover maybe both eyes, so both eyes, the good eye is not affecting the movement of the injured eye. Here, much more significant trauma seen here to the upper and lower eyelid, and a lot of edema and swelling, the discoloration and ecchymosis developing around and below on this eye. The visual fields will probably start to become obstructed as this starts to continue to swell. Here we show that they've actually caused some type of definite chemical burn. We can see that the covering and the cornea is now cloudy, and there's even a darkened spot where it looks like capillaries on the sclera have now been starting to coagulate and causing this small accumulation of blood. And you can see then on the outer aspect towards the lateral aspect where the blue glove fingers are, we also see the skin has also become chemically inflamed and irritated and is chemically burnt. So here they're showing us that the patient is using a self-operated eye wash, and they want to definitely continue to irrigate the eyes for over 30 minutes and to follow their local protocols or MSDS. We're going to continue to irrigate the eye until we get to the hospital. They're going to continue to irrigate and flush with lots of copious amounts of fluid and water. Here we're seeing that the eyeball is actually protruded outside the orbit. Globe is sticking out. We would not want to put any pressure to try to pop this back in, but we are going to be aware that there is possible that we put a lot of pressure, it can obstruct the vitreous humor, aqueous humor from moving. It can also affect the pressure on the retina. Again, put pressure on the retinal artery. So we want to protect this, and in some cases we may put a very rigid cup over this so that we don't put any pressure on this eye. Now, again, we want to use the trauma assessment sheet. This focuses a little more on just focus on the eye exam itself, but any part of the face, when we're dealing with this, if there's significant amount of trauma, think about the underlying structures such as the skull, the facial bones, and then internally the brain and other tissues, organs, blood vessels, and the like. Removal of contact lens. This may be easier done if the patient can do this, but If you need to, you're gonna be holding the eyelids open while you try to softly extract this soft lens. They also show you how to extract harder corneal lenses, and you may even use an applicator device to remove it. Here's a soft tissue injury along the chin or the mandible. This is quite close to the neck, so we wonder whether or not the trauma was significant enough to cause whiplashing or injury to the spinal cord. This does look like something took some type of claw or bite mark out of it. Also left a gaping hole that we can see. So I wonder whether or not this protrudes right into the oral cavity, and ventilating this patient, if needed, through a bag valve mask, would leak out through this this opening here. So we would put some kind of occlusive dressing, and if we needed to, ventilate them through the mouth and nose area. Again, facial injuries, they tend to bleed quite a lot. Focus on the soft tissue, but as we look into the soft tissue, understand the underlying structures, maybe blood vessels, bones, and then the internal organs that lie along the face and the brain itself. All right, please study your text, review your lecture notes, use your National Registry skill sheet to prepare for this, and practice. As we do our exam, go over and use DCAP DTLS. Do a focus assessment, do your neurological exams, check the pupils, see how they move. Are they equal? Do the movements, are they synergistically, or are they conjugated where they move together? All right, there's a lot to practice and a lot to do.